some of this. For those of you that were on during the patient care tech portion, you're going to see similar slides, but it's going to get far more in depth. So don't hop off thinking you don't need to see it or you already saw it. This is going to be more in depth for nurses. So our objective today is to identify the roles and responsibility of the nurse in the management of diabetes, understanding best practices of management of hypo and hyperglycemia, and obviously to apply appropriate and reasonable interventions to ensure patient safety. So just to review, why are we doing this? This was a strategic goal that Ascension had set out for fiscal year 2025. Our goal is to improve our number of patient days with a hypo or hyperglycemia event by 4%, which we did. So great job. We want to continue that improvement and keep pushing forward because we still can do better, I think. So why are we doing it? 27% of patients admitted across Ascension hospitals have diabetes, and the mortality rates are significantly higher for those that have severe hyperglycemia or hypoglycemia when they're admitted to the hospital. So it is a multidisciplinary collaborative effort. It takes all of us performing our roles within kind of the cog of the wheel in order for this to work and to work well. So the patient is our central focus, obviously. We want to incorporate them with an emphasis on empowerment, education, and self-management. Most of these patients know a decent amount of diabetes information. Some may not know much at all. We really want patients to self-manage their disease while they're at home, but also while they're here in the hospital, and to speak up when they think something's not right. So diabetes management is very complex. Every patient is very unique, and we can't just cookie cutter everyone. You guys know that a 5 or 10 unit dose of insulin is going to affect different patients differently. So we just need to keep that in mind. And then obviously we don't want to label or define patients as diabetic or non-compliant. It's just really derogatory practice to say, oh, the diabetic patient down here. Patients don't like that. They feel like they're being defined as their disease, which they shouldn't be. So just a culture shift in how we talk to and about our patients. So, and the ERS system has found that insulin is the most commonly reported medication class associated with patient harm, which probably doesn't surprise any of you guys on the call. So the benefits of inpatient glycemic control improved quality of care, a 1 to 3 day shorter length of stay, and a 200% higher cost when glycemia is not well controlled. And you can see the improved outcomes here when we're able to manage the blood glucose effectively. So let's talk pathophysiology. Before we get into what is going on with diabetes, I want to review what is normal. In a normal person, when they eat food, we are going to digest carbohydrates, proteins, and fats into the smallest particles possible. For fats, they're going to turn into lipids. Carbohydrates are going to turn into glucose, and proteins are going to digest down to an amino acid. Okay, those nutrients are pulled into your blood from your gut, and as the blood glucose increases, a normal patient's pancreas is going to produce insulin. That insulin goes out into the blood, grabs hold of the glucose, and pulls it into the cell where it can be burned for energy. So that's normal. There are multiple organs affected by diabetes. I won't go into this a whole lot. Just know that it isn't just about the pancreas. The liver, your adipose tissue, your kidneys play a role, your muscle plays a role, and also your brain. We're learning more and more about it every day. There are 2 types of diabetes, type 1 and type 2. Type 1 used to be called juvenile onset. Type 2 used to be called adult onset or non-insulin dependent diabetes. We no longer call them that because the lines have grayed. I mean, I'm an adult with type 1 diabetes, so I'm not a juvenile anymore. So it makes sense to just call me type 1. But type 1 is an autoimmune disease. The beta cells in the pancreas are destroyed by an autoimmune attack. That kills the beta cells that produce insulin. So it's usually a very quick, sudden onset. You were fine a month ago, you're not fine now, you don't produce insulin. And so that's when we see patients present to the ER with DKA and things like that. Their pancreas is basically destroyed. Diet, exercise, and other lifestyle changes cannot reverse or prevent the onset of type 1 diabetes because it's an autoimmune disease. Patients with type 1 are dependent on insulin for the rest of their lives. Whereas type 2 diabetes, this type 2 diabetes accounts for about 90 to 95% of all diabetes cases. So the vast majority of the patients that we see in the hospital are going to have type 2. It's caused by insulin resistance, meaning that the insulin that their body is producing is not able to grab hold of the sugar and pull it into the cells to burn it for fuel, okay? Over time, and having high blood sugars, it can actually destroy the beta cells that produce insulin. So now you're not only insulin resistant, but you also don't produce enough insulin. And so that's when you're going to see people with type 2 diabetes end up needing insulin for their treatment. Diet, exercise, and other lifestyle changes can affect the body's ability to produce and use insulin more effectively. And you guys are all aware that gastric bypass a lot of times can reverse or put into remission, I don't want to say cure, type 2 diabetes, because if they ever regain the weight, the disease is still there. So that's the differences. So let's talk about the glucose dysregulation that's occurring when you have diabetes. You eat the food, those things are digested, the nutrients get to the blood, but the problem is that the insulin resistance at the cellular level is not working to pull the glucose out of the bloodstream and into the cell. Or if I have type 1 diabetes, I'm not producing enough insulin or any at all. So that is the point at which things are dysregulated. So some reminders about type 1 diabetes, because it's only 5 to 10% of cases, I think a lot of times we assume an adult comes in with diabetes, it's going to be type 2. We have to be very careful that we know when we have a type 1, because if we omit long-acting insulin in a type 1, they're going to develop DKA quite quick. It's going to be very hard to control their blood sugars if things are missed or skipped or mistimed. Definitely never omit long-acting insulin in a type 1. If you're worried about hypoglycemia nocturnally, call the provider and request a reduction in the dose, okay? It would be much better to decrease the glargine dose than to omit the entire dose. Ensure there's no gap in long-acting insulin doses. And this really comes, the location that I see this the most is on admission. The patient comes into the ER, they got sick right before it was time for them to take their long-acting insulin, so they haven't had their long-acting insulin. Then they were in the ED for 10 to 12 hours, then they get admitted, and on admission, the glargine dose doesn't start until the next day at 2100. That's a problem for somebody with type 1, so heads up on that. Also, never remove an insulin pump for more than an hour, okay? Whether it's physically removed, for a shower or something like that, or dislodged or any of that. There's no long-acting insulin in an insulin pump. So the minute you're disconnected from the pump, you're going to start seeing the blood sugar go up and ketones to be produced. Okay. If the patient eats a carb, they always need the nutritional insulin. Okay. If somebody with type 1 diabetes eats a handful of crackers, let's say 6 saltines, their blood sugar is going to jump probably about 100 points just from 6 saltines. And that's because their body is not going to produce insulin to prevent that from happening after eating carbs. And typically, patients with type 1 tend to be more insulin sensitive than those with type 2. Finally, gestational diabetes is diabetes that's diagnosed during pregnancy. The patients that are at highest risk, you see there are the risk factors. These risk factors are the same risk factors for developing type 2 diabetes. Gestational diabetes carries a 10-fold increase risk of developing type 2 diabetes after pregnancy. So it's extremely important for patients that have gestational diabetes to be screened for type 2 diabetes every year thereafter. The risks of uncontrolled blood sugars during pregnancy, you can see there for the mother, it's preeclampsia, high blood pressure, C-section. For the baby, it would be macrosomia, respiratory distress, hypoglycemia. Remember, if the mother's blood sugar is elevated at the time of birth, that baby's pancreas is producing insulin trying to control the mother's blood sugar. So the minute the cord is cut, if the mother has high blood sugar, the baby's pancreas is still kicking out a bunch of insulin. So that's the reason for the hypoglycemia shortly after birth. Jaundice, fetal abnormalities, and stillbirth. So let's talk inpatient diabetes care. The glycemic goals as set out by the American Diabetes Association are listed here. You can see for intensive care units, it's 140 to 180 for the vast majority. Non-critical care units, 100 to 180, same for the OR, and you can see OB and labor and delivery as well. So we need to align with best practices in terms of monitoring. Obviously, if somebody is NPO or they're on nutrition support, we need to be doing Q4 finger sticks because we're probably feeding that patient 24 hours a day with the nutrition support. If they're on an oral diet, it should be ASJHS or AC and HS and 0300 for those that you're worried may have hypoglycemia overnight. The critical glucose levels are listed here. You can see that I've highlighted that our new critical level for the low glucose level is now less than 54. The lab will be calling glucose levels that meet this criteria. Obviously, the hypoglycemia protocol is initiated at less than 70. And our glucometers will produce a result between 10 and 600. Anything less than 10 is going to read low. Anything greater than 600 will read high. And, you know, obviously at that point, we need to be doing a lab glucose in order to accurately define how high or how low their blood sugar is. Nutrition. Our goal is to ensure adequate nutrition for healing while maintaining glycemic control, and that can be tricky for people with diabetes. The average hospitalized patient only eats, I mean, a lot of them eat less than 1,000 calories per day. Definitely consult your dietitian if indicated. And remember that patients with diabetes can eat sugar. It is a carbohydrate, just like any other carbohydrate food, and we can account for that in their meal trays. So if they're not eating well and they want chocolate pudding, I can promise you the dietitian's going to be fine with it, whatever they'll eat. So we just need to approach it, and we need to get adequate calories in the patient. And if that means carbs, we're probably going to need to adjust insulin to manage their blood sugar. The best approach for glycemic control means to count their carbs at mealtime, being consistent from meal to meal, and matching the mealtime insulin with carbohydrates eaten, which brings up one more thing I want to mention. Later this month, in about 3 weeks, we're going to roll out a new insulin subcutaneous order set. For Tulsa hospitals, this is going to give you the ability to adjust the mealtime or the nutritional. I want to call it nutritional because it isn't your sliding scale. It's your nutritional insulin based on how well the patient eats. You're going to get new comments on that order that say, if the patient eats 50%, you're going to cut this dose by 50%. So if they were ordered 10 units, the patient eats half the tray, you're only going to get 5. It's going to be far more flexible. And that way the nurses don't have to stand there and think, do I give the dose or do I not give the dose? Because right now it's either or, there's no adjusting. So that is coming. And then obviously monitoring outside food and drinks brought in by family members. Remember, they're not eating well. So if they bring in Wendy's or Taco Bell, we just need to do everything in our power to try and figure out how much is 60 grams when we're talking Taco Bell. There is an app called calorieking.com. I put that link on the Diabetes Care Good Day Ascension page. So you can easily look up Taco Bell taco, Taco Bell bean burrito, whatever it is. and figure out how many grams of carbs are in those items. And then just talk to the patient about the diet order says you're on a 60-gram carbohydrate limit. So this is what 60 grams says, and kind of walk them through why that's important. So carbohydrates, there are 3 main nutrients, like I mentioned at the beginning, in food that we eat: carbohydrates, proteins, and fats. Carbohydrates are the foods that are going to affect the blood sugar the most because it is going to digest and metabolize into glucose. Okay, you can see in the little graph here, that dark bold line is the effect of carbohydrates on blood glucose over time. You can see your blood sugar is going to spike and then come down pretty quick after eating carbs, whereas proteins and fats are the dotted and dashed lines. They have a more blunted effect on blood sugar. That's why we don't typically count those when we're trying to control blood sugar. So what's a carb? Anything in the starch, dairy or milk group, fruit group, and anything dessert-like with sugar on it. All of those things are going to digest into glucose. It doesn't mean that any of those foods are bad foods. It just means we need to count them. If my limit is 60 grams or 45 grams, I'm going to count those carbs and just make sure that I'm not going over the limit. What is not a carbohydrate would be any proteins, meats, eggs, cheese, fats like butter, margarine, salad dressing, oils, nuts and seeds, and then any free foods. Patients with diabetes who are carb counting love free foods because they can eat them and not worry they're going to affect their blood sugar. And really the most common one that we use here in the hospital is going to be sugar-free Jell-O. Okay, there's actually no carbohydrate in that. So we here offer 3 carbohydrate level diets: 45, 60, and 75. That means that the dietary department is going to count up and try and be consistent for breakfast, lunch, and dinner and provide that amount of carbohydrate. That allows the doctor to adjust insulin, based on the assumption that they're getting 60 grams per meal. If we were to do a low carb diet when the patient had a nutritional insulin dose, they're probably going to go low. So the importance is consistency and to count the carbs. Obviously, if you've got somebody who's still hungry or whose blood sugar is really high, but they want a snack, try to use the low carb snacks, things that aren't going to affect the blood sugar further, like a cheese stick, sugar-free Jell-O, diet soda, broth, maybe calling down to dietary and getting a veggie tray with some dressing. They could snack on that and you wouldn't have to worry that their blood sugar is going to go up. Things that are high carb are ice cream, sherbet, sugar-free pudding. Yes, sugar-free pudding is a carb because you mix it with milk. Regular soda, milk, and juices. I will point out, a lot of people are not aware that ice cream, our little ice cream things that we serve, are 15 grams of carbs, whereas the sherbet is 30. It's double the sugar than ice cream. So heads up on that one. If the patient's still hungry and they're a 6 foot tall, 220 man and 60 grams is just not enough for them, definitely consult the dietitian. They can work with the patient to double their protein, add veggies, extra veggies to the tray, or other foods that are not going to increase how many carbs they're getting at each meal. So hardwiring the mealtime process is super important because timing of insulin, timing of the finger stick blood sugar checks, what time the trays show up, can cause hyper and hypoglycemia because we can mistime insulin doses. We really need, as nurses, to make sure that we're trying to give the mealtime insulin dose as close to the meal as possible. So if the nurse aides, we're going to work ahead and it's 10:30 in the morning and I've got time, I'm going to go do my vitals and quickly go do that because they're not thinking through the repercussions of that. You could be giving a sliding scale insulin dose based on a blood sugar that's an hour and a half old, which is not good. I can promise you an hour and a half is a long time when it comes to blood sugar. So the coordination of care between the dietary department, nurses, and PCTs is super important, and we really want this mealtime process to be hardwired. Dietary is going to call the floor and notify the nursing unit when the cart leaves the kitchen. That is the red flag. That is the time that the nurse aide needs to go start checking vitals, getting finger stick blood sugars. And then they need to notify the nurses of those results immediately. Once dietary makes it up to the nurses station, they're going to notify nursing again, hey, the trays are here. Whoever is getting that information at the main nurses station needs to use some kind of communication, whether it's a Zebra or I think some places use cell phones. I can't remember what they're called. Starlink, it's not Starlink. They have cell phone devices to text that out to all the nurses and nurse aides just to say, hey, the trays are here. That way, if they're behind and haven't gotten finger sticks, they can hop on it and go do it. Dietary is going to then go to pass the trays. They're going to ask the patients that are on consistent carb diets, has your blood sugar been checked? If the answer is no, they're going to push the call light. That is going to be the third notification that, hey, the tray has been dropped off. The nurse can administer insulin. This is beginning at the end of this month when we roll out the new insulin subcutaneous order set. The nurse is going to have a choice. If you've got a patient who eats routinely well and you have no doubt about them eating well, you can give the insulin immediately before the meal, okay? If you're questioning whether or not the patient's going to eat, I would hold off. Wait until after the patient's eaten at least half of the meal before deciding and giving the insulin dose. More to come on that. So I did talk to the patient care techs about making sure that they're documenting PO intake accurately, as well as consistently. Our PO intake percentages that we're documenting are very inconsistent. And so one thing that I'm going to be talking to the aides about is getting that information in there, because you're going to need that to dose the insulin off of. Providers need that information, dietitians need that information, diabetes educators, we're all using it. And so working together during this mealtime process is going to be extremely important. Insulin in the hospital. So let's talk about insulin. And I want to first talk about what is normal. In a normal person, a normal pancreas is going to produce insulin all day long, little bits just to maintain steadiness. And you can see that here in this graph. There's always a little bit of insulin hanging around in the plasma. And then when a patient eats, their blood sugar is going to start to climb, but they're also going to have a quick burst of insulin produced by the pancreas. And you can see that at breakfast, lunch, and dinner here in this illustration. Our goal with insulin for people with diabetes is to try to mimic this with insulin that we're injecting to the patient. So the different types of insulin, I've listed here only the insulins that we have on formulary. So there are a ton of insulins on the market nowadays, but I really wanted to focus in on the insulins that are on our formulary that you're going to be using day to day. So glargine is the long-acting insulin, okay? There's no pronounced peak. You can see in the graph, it's a very flat-acting insulin. Its onset is 2 hours. So at bedtime, if the blood sugar is 100 and you're worried about the glargine causing a low blood sugar, go ahead and give the glargine and maybe give the patient a small snack. They're going to be fine because the snack is going to raise their blood sugar a little bit and the glargine's not going to work for 2 hours. Those of you working in critical care, I do want to point out, because glargine takes 2 hours to start working, you need to overlap the IV insulin. If you're taking somebody off of IV insulin and onto sub-Q insulin, you need to give the glargine dose, wait 2 hours, then turn off the IV insulin. That is going to prevent a rebound hyperglycemia as you come off the insulin drip. And we're not real good at doing that. The new DKA order sets, I will point out, I don't think do a good job at putting this in front of the nurse. And that is one of the changes that I'm going to recommend moving forward when we're able to make adjustments to those national order sets. MPH is an intermediate acting insulin. We typically don't use that much in the hospital. And here's why. You can see in the illustration here, it's got that big peak in it. So using it for a long-acting insulin by giving it twice a day, you're going to have these peaks. Those peaks are fine as long as the patient's eating breakfast, lunch, and dinner and eating a bedtime snack every night. But if you have to make them NPO for any reason and that insulin peaks, you're going to have a low blood sugar. So we typically don't use MPH a whole lot, but you will see doctors using MPH to cover the rise in blood sugar with prednisone. It is really good because it wears off about bedtime, as the steroid will as well. So the patient's going to wake up with a decent blood sugar, and you're going to give the prednisone, and it's going to rise lunch, dinner. You're going to have some pretty high blood sugars. Whereas if you give an NPH dose with that prednisone dose, it can blunt that rise in blood sugar. It works really well for that. Rapid acting insulin, we use Lispro. It starts working in less than 15 minutes. Just depends on the patient. Some patients less than 10 minutes. So we don't want to give this any earlier. If the food trays are not on the floor, I would not give this insulin until the food is sitting in front of the patient, for sure. Because if something delays the food and you've already given the Lispro, you're going to have a low blood sugar. Okay. It does peak, and these are sub-Q durations and peaks, by the way. It does peak at 30 to 90 minutes, okay? Short-acting insulin regular, for the most part, we're using regular only for insulin drips. Maybe the ER uses it for IV pushes and things like that, but it is slower. It takes 30 to 60 minutes to start working, so it's harder to time at mealtime than say, Lispro. I want to kind of get everybody on the same page in terms of nomenclature and what we call things. Basal insulin is the long-acting insulin. You can see it in the red line there. That is what we will call basal insulin, and what the literature uses to, I guess, distinguish between the rapid-acting insulin that's given at meals and the long-acting insulin that's given once or twice a day. It's meant for stabilizing between meals. It's meant to be dosed so that if a patient is NPO, they do not drop low. With that said, a lot of patients come into the hospital over basalized, meaning their primary care doctor just keeps cranking up the glargine or the Tresiba or whatever they're on, trying to keep the patient on one shot a day. But what happens is overnight they're having lows. They're probably sleeping right through them and don't even know. If they fail to eat a meal, they drop low. And when we get them into the hospital and we control their diet, they drop low. So really, we're going to aim to not allow them to go low overnight. And I've been talking to the doctors about reducing the dose the patient's taking at home when they get admitted, up to 35% to try and avoid low blood sugar. Because you and I both know we're going to make people NPO. We're going to take them for testing. And that's a risk. Okay. Definitely never omit basal insulin. I know that a lot of nurses will hold the glargine at bedtime for various reasons, usually because they're afraid the patient's going to have a low blood sugar. But it is out of scope for a nurse to hold an insulin dose without a provider's order. So definitely call the provider and request a lower dose. Skipping, like I said earlier, skipping basal insulin or glargine at bedtime for somebody who has type 1, they can be a DKA the next morning. And that's a real risk. So I just gave you another couple little tips. If at bedtime the blood sugar is below, say, 120, maybe just give them some saltines and a cheese stick or a carton of milk, and go ahead and give the glargine. But I definitely would be talking to the doctor about getting the glargine dose decreased by 10 to 15% if you're worried that they're going to have a low. Bolus insulin. This is the amount of insulin that we're giving at mealtime. There are two different components. As you guys know, a lot of times patients have a nutritional dose, and I'm calling it nutritional rather than a meal dose, because you also give correction doses at mealtime. So I don't want there to be any confusion. A nutritional bolus or a nutritional insulin dose is intended for the food that they eat, whereas a correction dose is meant to correct a high blood sugar down to a target. And our sliding scales are targeting 140. So they're going to try and bring the blood sugar down to 140. And just like normal insulin production, we're trying to, like I said earlier, mimic what your body should be doing. And we're mimicking it by using insulin injections. And like I said earlier, timing is everything. We need to give it as close to the finger stick and the meal as possible. The goal would be to be giving it within 30 minutes of the meal. And definitely, if the finger stick blood glucose result is older than 60 minutes, you need a new one. Have your aide go check it again before you give any corrective sliding scale doses. So basal bolus insulin is basically a long-acting insulin to maintain stability glucoses all day. It's generally dosed once or twice a day. And then you have bolus nutritional insulin and bolus correctional. The ADA is recommending that most patients admitted to the hospital need this method or this type of insulin regimen. But not all type 2 patients, if a patient comes in and they have type 2 diabetes that was well controlled on diet or pills at home, they may not need the nutritional piece of that, and they may only need some glargine and a correctional scale, and they could do fine. So I do want to point out down here in the bottom this warning about insulin stacking. Insulin stacking is when we give 2 subcutaneous correctional insulin doses too close together. Remember that I told you that Lispro peaks at 90 minutes? Well, if you give 2 sub-Q doses, within 2 to 3 hours, you're basically stacking 2 doses on top of each other before the first one has even had time to lower the blood sugar. And so you can get some very rapid low blood sugar. And the one example that really stands out to me is a really high blood sugar. And you call the provider and you say, hey, I checked the blood sugar, it was 500. And the doctor says to you, give 10 of regular or 10 of Lispro now, and recheck the blood sugar in 30 minutes. That never is a good plan because that insulin hasn't even peaked yet. Checking in 30 minutes is too quick to see a drop in blood sugar. You really need to wait probably 2 or 3 hours before a second dose is given. That's not the case for IV. If you're doing IV bolusing of insulin, that could be done every 30 minutes because the duration is much, much quicker. Okay. Any questions to this point? I don't want to blaze through this. If anybody has questions, please definitely raise your hand, and I can slow down. So basal bolus dosing, like I mentioned before, most hospitalized patients will require that. The rest will need basal plus correctional. Definitely sliding scale or correction scale only is not recommended by the ADA. With the caveat that within the first 24 hours, we don't really know how much insulin a patient may need. And so it may be appropriate to start somebody on just sliding scale to see, hey, are they going to need some long-acting insulin too? So keep that in mind. Dosing varies based on several factors. You can see there, patients with poor renal function or a GFR that's less than 60 are super high risk for that insulin hanging around longer than it should, and therefore low blood sugar. One thing that Dr. Hefner had asked me to mention during this talk is patients who have diabetes, who are having high blood sugar, and they're on steroids. He really would like to see the nurses call the provider and ask, hey, can we decrease the steroids? This patient's blood sugars are in the 300s. One thing about the Oklahoma market within Ascension, we use significantly more steroids than all of the other ministries in Ascension. And so there is a real push by pharmacy to try and get the providers here to use smaller doses of steroids and less of a duration. So it is totally appropriate as a nurse to speak to the doctor about, hey, can we decrease these steroids for this patient? That may just be kind of the poke that they need to back off a little bit. So dosing calculation options. We do a lot of weight-based dosing calculations within our diabetes care team. But you can also take their home doses and just decrease everything. A total daily dose based on the weight can be calculated. And what we typically do, what's normal, is to do 50% of the total daily dose as your long-acting insulin or glargine, and then the other 50% split over the 3 meals, and then add a sliding scale in case you need it. So for example, if the patient needed 60 units in a 24-hour period based on the weight-based calculation, you would do 30 units of glargine daily, and then 10 units Lispro TID, which adds up to be a total daily dose of 60. Let's talk about our correction scales for just a second, because I think they can be pretty confusing. Not everybody understands what the numbers on those scales mean, and I think it's important. Each scale is going to include both a blood sugar target and a correction factor. A blood sugar target is the point at which we want to drive the blood sugar down to, okay? And that you will see as pink here in this illustration. The correction factor is how much 1 unit of insulin should lower the blood sugar. So for example, the high risk of hypoglycemia scale has a blood sugar target of 180. The reason being, we don't want to overcorrect these patients. They're already at high risk of low blood sugar, so we've upped the target. We don't want to overcorrect. And then we're using a correction factor of 60, meaning 1 unit should drop their blood sugar 60 points. It really should be used for patients who are thin, severe renal impairment, they're extremely insulin sensitive. At home, they probably take less than 25 units a day. That would be a good group of people to use this scale for. And you can see the sensitive scales, the 140-40, the target's 140, and 1 unit should lower the blood sugar 40 points. And it just goes down from there all the way to the resistance scale with a correction factor of 15, meaning 1 unit only drops the blood sugar 15 points. And you can see that that scale really should be reserved for those with type 2 diabetes. They're obese, they've got significant insulin resistance, and they're using 90 or more units of insulin. I think one thing that we're not really good at is when the blood sugar is not well controlled and we're trying to drive it down, we typically overuse and get a little over aggressive with these scales trying to lower the blood sugar, when really the problem is we need more basal insulin and more bolus insulin at mealtime. Okay, we don't need to keep cranking up the correction scale because that can actually drive them too low. Okay, so let's talk critical care. The gold standard for critical ill patients is going to be continuous IV insulin infusions using either a written or computerized protocol. That really has been well established within the literature. I do want to point out for those of you on here who work in critical care, we are in the process, we've already contracted and are in the process of building out EndoTool IV for use in the ED, the ICUs, what else? OR, and hopefully also OB as well to control blood sugars. It is a computerized protocol that will integrate into Cerner. So it will basically, the nurse will enter what the blood sugar is, and the computer algorithm will say, you need to change the insulin drip to this. Those computerized protocols have been shown to really decrease the risk and the incidence of hypoglycemia and get the blood sugar down to target much quicker than some of the paper protocols that we use. So more to come on that. That's probably, I would say probably 6 months to 9 months out, but we are currently building it and setting that up. So non-critical care, the gold standard is basal bolus insulin, whereas it is far more preventive in nature. We know that, you know, the patient, when they eat, their blood sugar is going to spike, so we're going to give a dose of insulin to prevent that. Whereas correction scale is very reactive. And when you have a sliding scale, you're not giving insulin until they're already high. And all that scale is trying to do is knock it down. And because you're using a rapid acting insulin, it's only going to knock it down for 4 hours. And then you're going to have to do it again. So the gold standard in these patients is going to be basal bolus insulin. Just a quick little reminder, multi-dose vials, insulin syringes, if drawn up, must be labeled and should have a 2-person check. Omission of insulin, I've already kind of mentioned this a little bit, that holding insulin without a provider order is out of nursing scope of practice. You need to call the provider and request a lower dose. And like I said before, just to highlight it again, holding a basal insulin dose can and does, and I've seen it happen in our hospitals, can cause DKA in insulin deficient patients. And holding nutritional doses, even though the patient ate well, you know, their blood sugar is going to rise after meals, so you don't want to do that. Let's talk a little bit about diabetes devices. On your units, you should have a nursing reference binder with all of, like a ton, way more information than you would maybe ever need in those binders about insulin pumps, the different pumps that are on the market, what they look like, how they function, as well as the continuous glucose sensors. If you cannot find that notebook, I've also put the link to that notebook on our Diabetes Care Good Day Ascension page. So you can easily go to that and look things up and get questions answered about a patient on a pump. So a basic pump only uses rapid acting insulin. It's set up to drip over 24 hours with basal rates that are preset. And then a patient will enter how many grams of carbs they're going to eat, as well as what their blood sugar is at mealtime, and bolus themselves for the meal. There is new technology called automated insulin delivery devices. They are hybrid closed loop technology. I would say the vast majority of patients on pumps are now using this newer technology. The pump and the sensor are wirelessly connected and communicating to each other 24 hours a day. So if the blood sugar is rising, the pump is going to give extra. If the blood sugar is dropping, the pump is going to shut off and wait until the blood sugar kind of rebounds back up before it restarts. So keep that in mind when your patients come in. I do want to point out that even if they're on a hybrid closed loop pump and sensor combo, they still have to enter what they're going to eat at mealtime and what their blood sugar is in order to bolus at mealtime. It's not totally hands off, at least yet. At some point that will happen, but it hasn't happened yet. And definitely keep in mind that these patients are at high risk of DKA because they don't have long-acting insulin on board. You can become disconnected at the site. You can have an occluded or kinked cannula underneath the skin, and I've seen that happen in the hospital, and it's happened to me at home. So just keep that in mind. If blood sugars start to creep up and they're not coming down, when the patient corrects with their insulin pump, we need to assume there's something wrong with the pump, remove the pump, replace the insulin, replace the site, the tubing, everything to try and eliminate the problem. I think a lot of times we drag our feet because we're not quite sure about pumps and what we should do, but that is our policy. If the patient's blood sugar is greater than 250 and we correct it once with the pump and it doesn't come down in 4 hours, we're to give an injection with a syringe to ensure the patient gets the insulin and then change everything out. Any questions about pumps? I can go in more detail if that's needed. So what do you need to do as the nurse? You need to make sure that the patient has brought all their supplies in, okay? Patients are going to have to replace or refill with insulin, replace the tubing, replace the cartridge, everything, every 3 days. And so if they don't have what they need to do that, we're in a pickle, especially if that happened, if their pump runs out of insulin at midnight. So make sure that they've brought in supplies. Ensure that the provider has ordered the insulin pump order set in Cerner. There is a lot of reference text within that order set to help you, the nurse, out. They need to sign the insulin pump consent and have the bedside flow sheet so they can document how much insulin they're bolusing from their pump at mealtime. We also need to continue to monitor blood sugars with the hospital meter. We can't use glucose sensor readings because it's not FDA approved to do so. A lot of patients aren't going to understand that, but if you, explain it, they usually are fine with it. As I've mentioned before, don't disconnect a pump for more than an hour. And then also make sure that the insulin pump notify consult has been entered, and the diabetes educators will come and make sure everything's going well with the pump, and that we're documenting settings, etc. Continuous glucose monitors, also known as glucose sensors, as I mentioned, are not FDA approved. CGMs are in the fat tissue, and so what they're doing is checking interstitial fluid. They're not like a finger stick, in that a finger stick or a glucometer is checking capillary blood. And therefore, the data on a glucose sensor is going to lag behind 10 to 25 minutes of the finger stick. Another reason we need to be doing finger sticks. The data that the patient is getting on the sensor will rarely match a meter, okay? And that's because of this time lag. And a lot of patients aren't aware of this. They may not have been educated on how that sensor technology is working. And so they can get kind of argumentative about wanting to wear their sensor. But if you need to consult the diabetes educator, we can kind of come up and talk to them about why that's important when they're sick and when they're in the hospital. Okay, hypoglycemia. Just some updates about why it's important. Higher risk of mortality. 84% of patients with severe hypoglycemia had another mild hypoglycemia event during that same admission. So if somebody has a low blood sugar, they're high risk to have another one. And really, I really want to highlight that final bullet because I think it's extremely important. After hypoglycemic events, 75% of patients do not have a basal insulin dose change by the provider, meaning they had a low and no one decreased the insulin. Like, I can't tell you how many times day after day we see a patient with a fasting of a blood sugar of 60. And the next day they get the same amount of basal insulin the next night. And I'm like, why are we not decreasing this dose slightly? So we are doing a lot of provider education and telling them, if you have a patient who's on insulin and their blood sugars are dipping below 100, we need to back off on the insulin. That's the only way we can prevent hypoglycemia, is getting ahead of it and not waiting for it to happen. So there is a big push there. The hypoglycemia protocol obviously is going to implement for any blood sugar less than 70. These are the symptoms that you guys are all familiar with. Again, we're trying to tell the doctors to reduce their insulin doses if the blood sugar drops below 100. The American Diabetes Association has pushed out some new guidance on what they consider mild, moderate, and severe. So I wanted to highlight that real quickly. Again, this is another reason we changed our critical to less than 54 so that we could stay ahead. Best practices, institutional safety is prioritized through proactive prevention. You guys have seen the new hypoglycemia protocol, and you hopefully have seen the prevention steps. If you have a patient with a blood sugar less than 100, you're to give them either a PO, a small snack of cheese and crackers, a glass of milk, something with some carbs and some protein in it to bump their blood sugar up until the next meal. And if they're MPO, to hang D5 at 50 and call the provider. We're trying to prevent hypoglycemia rather than react to it. And finally, just another tidbit to highlight down at the bottom. The hypoglycemia protocol, if you've read it, is really pushing the use of medical carbohydrates rather than foods for treatment. And that's because you're able to give more predictable carbohydrate to the patient, as well as if you're barcode scanning those products, whether it's the glucose gel or the liquid, it's going to document that you've treated the low blood sugar more efficiently and effectively. Hyperglycemia management. So like I talked about with basal bolus insulin, this too is what we've been talking to providers about. I have pushed out some provider sheets and that little colorful graph there, you can see that. You may see those around in the dictation areas or in the nurse's station. These provider cheat sheets are there for the providers to kind of be able to better assess how much insulin a patient may need based on their BMI, how much insulin they take at home, et cetera, et cetera. So we did push that out. Clinical assessment of the high-risk groups of patients for hyperglycemia are going to include, obviously, those with a history of diabetes, those that are older, those on steroids, Dilantin, diuretics, and some antipsychotic meds. Abilify comes to mind as one that can cause some severe hyperglycemia. Obviously, omitted or missed insulin doses, extreme infection and stress, all of those things can cause high blood sugar. So monitoring is important. Obviously, we're doing finger sticks as ordered, but also an A1C should be measured in all patients with diabetes or hyperglycemia, in whom their chart doesn't already have one from the last 90 days. The point of care glucose meter is currently the recommended method. I can tell you that our stat strip meter is highly accurate. It's the most accurate on the market. And I'm really glad to say that our hospital has the most accurate meter. Obviously, if the patient's symptoms don't match the result you get, you need to retest. Usually it's user error. If we get some kind of erroneous, either we didn't get enough blood on the strip, maybe the finger was still wet when we poked it and it's a diluted sample. A lot of things can happen on the user side, so we just need to make sure that we're following all those steps. Just some reminders about nutritional therapy. Our goal being that we provide enough nutrition to meet their needs, but that it's not causing high blood sugar. Know that the dietitians, anytime that TPN is ordered or nutrition support is ordered, they are calculating how many grams of carbohydrates are given, and making sure that we're not overfeeding patients with nutrition. Steroid therapy, no shock here. Steroids raise blood sugars. And like I said before, Oklahoma is the market that uses the most steroids. And so we're really trying to push the use of less steroids. And as I talked about MPH, it is really good for intermediate acting steroids like prednisone, because they work, their duration, their peak and onset and all that good stuff are very similar. So just keep that in mind. Some quick information about DKA and HHS. They are the most serious and life-threatening hyperglycemic emergencies people with diabetes face. It's super important that we start managing them in the ED and continue on into the ICU. We do have new DKA and HHS order sets that rolled out, not quite a month ago. It looks like 3 weeks ago. DKA is most common in patients with type 1 diabetes, but can occur in those with type 2. It's usually sudden. It happens over a matter of hours, and it usually indicates that there is a complete lack of insulin available. When that happens, your body's going to use fat to produce energy, and the byproduct of fat metabolism is ketones. They're going to have increased acidity. You're going to see the bicarb, the anion gap, all of that stuff gets deranged. There is a decently high mortality rate with DKA, and you can see what you're going to see on the labs there below. And the treatment for this obviously is fluids because they're dehydrated, but also insulin. Without insulin, you can't stop the ketosis. Insulin is what's going to pull the sugar out of the cell and to allow the patient to metabolize the glucose rather than the fat in their body. So hyperosmolar hyperglycemic syndrome, or HHS, is a bit different. It's most commonly found in type 2 patients. A lot of times it's elderly patients who have had a UTI. They have not stayed hydrated. It is gradual. It can take days to a week to actually develop. They are going to be extremely dehydrated, even more so than a DKA patient. And because they are extremely dehydrated, the concentration of glucose goes skyrocketing. So you can see patients with 1,000, 1,500 glucose levels. And you can see here the mortality rate for HHS is far higher than DKA. It's 10 to 50%. It's very, very dangerous. You'll see a blood glucose greater than 600. but look, you don't have ketones. Ketones are usually negative, maybe trace, you may have trace, but they're usually negative. The pH and the anion GAT, the bicarb are usually normal, not indicating acidosis, and that's how you know it's HHS. The treatment is fluids, 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 and a little bit of insulin. It doesn't take much insulin to get these patients under control. They can be sometimes 10 liters down in terms of their fluid balance. So we push fluids, hopefully not so fast that we cause other issues, but fluids is what's going to lower the blood sugar in these patients. Here you can see the different clinical features of DKA and HHS with the differences, oops, sorry, that I've highlighted here. These are the differences. In DKA, you're gonna get acetone breath. They're gonna be huffing and puffing because what are they trying to do? They're trying to breathe off that acid. Nausea and vomiting, abdominal pain. It's very rapid onset. The patient missed their dose of glargine the day before, and oopsie, here we are in DKA. Or they got disconnected from their insulin pump overnight, or the pump ran out of insulin overnight. That happens. Those things happen. HHS, a little bit different. It's slow, usually older age, more common in type 2. And like I said before, the typical patient's going to be elderly with a UTI. They just don't feel the thirst and don't realize they need to be drinking, and they can get extremely dehydrated. So the new DKA and HHS order sets, you can see here some of the basic keys to that. You've got an immediate 2-liter IV fluid bolus over 2 hours. And then the doctor needs to order three fluids, a maintenance fluid, and a D5 and a D10, because that's what's going to titrate more so than the insulin dose on those IV insulins. We also now have a euglycemic DKA order set, euglycemic meaning normal blood sugar. There is a new drug class on the market. I'm sure you guys have heard of Jardiance. They've got all their little commercials where they're singing about Jardiance. I don't know how anybody doesn't know about it, but these are the sodium glucose transport inhibitor drug class. These drugs actually cause your body to release more glucose through the urine. And so these patients can get dehydrated if they're not keeping up on their fluids, but they can also go into DKA and not realize it because their blood sugar may be normal, but they start vomiting. And so I think a lot of providers, primary care providers, are not telling their patients that they need ketone strips at home. Make sure if you start to vomit to check for ketones at home. And so these patients are coming in to the ED occasionally with normal blood sugars, but all the acidotic lab work. The ketones are there, the bicarb, the GAP, all of that stuff is deranged. And early on when that drug class came out, the doctors were sitting there thinking, it looks like DKA, but the blood sugar's not high. So it's very confusing. So this new DKA order set actually runs D5 or D10 concurrently with the maintenance fluids. And that's to keep the blood sugar up while you're still giving insulin and resolving the ketosis. We also now have a mild to moderate DKA subcutaneous insulin order set. It does not require the patient get admitted to the critical care unit. However, I think that most of the hospitals have decided, regardless if we're going to use subcutaneous or IV, they're probably for now going to still send them to ICU to be managed, but we'll see moving forward if we have some patients. You know, I think there are a lot of patients that come into the ER that have mild DKA that given an extra dose of glargine and some Lispro, we could probably get them out of DKA in a matter of hours and send them home without admitting them. So I hope to see this used in that manner, and maybe we can free up some beds. Just some more information about when to call a provider, et cetera, et cetera. I don't know, there's 20 of you guys on here. I'm not sure how many of you are from ICU, but if you want more information about these order sets, definitely reach out and I can get that to you. Okay, so keys to managing hyperglycemic emergencies. Long-acting insulin paired with IV insulin does not minimize time to resolution. There are a lot of providers there for a while that would give a dose of glargine and then start the patient on an IV insulin drip, but the literature doesn't support that. Balanced crystalloids versus saline for fluid resuscitation was recently shown in the literature to reduce resolution time. So you're going to see the use of LR a lot more than normal saline for those initial IV boluses. IV bicarb should not be given unless the pH is less than 6, just because of the risks. And IV insulins without an initial IV bolus improve safety and have better outcomes. So we used to give like a I think it was 0.1 units per kilogram IV bolus, and then we would start the IV insulin drip. That really isn't needed anymore. They say just start the drip. Okay, any questions about DKA or HHS? Okay, hyperkalemia, just a quick little tidbit about that. Just be aware, you know, because we're giving insulin and D50, to watch your patient closely for hypoglycemia. We have seen quite a few hypoglycemia events after hyperkalemia treatment was done. And so we are working with pharmacy. I think pharmacy's planning on pushing out a new hyperkalemia protocol very soon. So be aware of that. Like I mentioned earlier, we are getting an updated insulin subcutaneous order set. That's going to happen in 2 or 3 weeks from now. I think it's about 3 weeks. It's going to be set up in the basal bolus format, you know, with the basal insulin being glargine and the bolus insulin being nutritional and correction scales. And you can see the scales down there. If you're on here today and you're from Bartlesville, you will be gaining new correction scales. If you're in the Tulsa area, Wasso, BA, Sapulpa, any or main campus, you will be gaining these comments that are under the nutritional dose. And you can see if the blood sugar is less than 80, because it's a little low, we want the food to raise the blood sugar a little bit. We're going to cut what's due in half for them. And you can see what I mentioned earlier for consistent eaters, give with the first bite of the meal. If you know they're going to eat, go ahead and give full dose. If they're not very consistent or you're not sure they're going to keep down what they're going to eat, wait and give it immediately following as listed below. Obviously, if they eat less than 25% or if they're MPO, you're going to hold that dose. You're going to give half if they eat about half, and you give the full dose if they eat more than half. So that is going to give us a lot more flexibility at mealtime and a whole lot less hypoglycemia, hopefully in the Tulsa hospitals. Okay, I've got a basal bolus insulin example. Here's Mr. Johnson. He's been eating well since admission and has the following orders. His finger stick blood glucose at lunch was 232 and he ate 100% of the meal. How much Lispro do you give Mr. Johnson for lunch and when? Here are his orders. He's got 8 units of Lispro ordered TID food, and he's got, it looks like the sensitive 140/40 scale there. Anybody want to put their thoughts in the comments? If not, I can kind of walk through it. So the nutritional dose, he ate 100% of the meal. So he's going to get 100% of that dose, which is 8. And then the correction dose, because he's 232, he's going to get 3 units, right? Add those 2 together, he's going to get 11. And Molly and Kylie were spot on. Good job. Okay, Mrs. Smith is not a big eater. She's not been feeling well. We're not sure if she's going to eat. Her finger stick blood glucose at dinner is 73, so right on the edge. And she only ate 50% of her meal. So what are we going to do for her? Three units for the meal, but guess what? She's below 80, so we're going to cut that in half. 1.5. Hopefully you've got a 3/10 cc syringe that will measure down to the half unit. And then her correction is 0 because her blood sugar is 73. By cutting the 3 to 1.5 is going to allow that 73 blood sugar to kind of creep back up a little bit naturally. Make sense? Kylie says, oh man, yep, it was a trick. But it's a new trick. It's a new trick, and it's a new flexibility that nurses are going to have to be able to adjust the insulin and feel better about it, knowing that you're not going to cause them to go low. Okay, patient education. This is super important. I've got a lot of education resources on the floors, and if you don't have access to them, let me know and we will make sure to get them to you. But I do want to point out all patient education is directed by you, the bedside nurse. Super important. To start early in admission. Don't wait until they're discharging home to start talking to them about their diabetes. And I don't think that typically happens. I think you're probably talking to them daily about various topics. And really, from the hospital, we're not expecting you to tell them A to Z everything about diabetes. They are not going to comprehend it. They're not going to remember it because most of them are not feeling well, right? So really the question I want you to ask yourself, is the patient safe to discharge home? If the answer is yes, you're good to go. If not, then we need to do some education and make sure they have what they need to be successful. I have put basic survival skills notebooks, and you can see a picture of it right there up in the upper right-hand corner on every nursing unit. There are QR codes to demonstration videos of how to use an insulin syringe, how to use a glucometer, and how to use an insulin pen. The whole purpose of that is so that you don't have to stand there and teach that skill. You can have them scan the code with their phone, and the video will walk them right through it, and then they can ask you questions if they have questions. The Diabetes Care Good Day Ascension page has even more nursing resources. We've got a preventing DKA flyer meant for those patients that came in with DKA. Maybe they're having a hard time affording insulin. We've got a Making Insulin Affordable flyer. We also have laminated diabetes discharge checklists for nurses. So what do you need to make sure the patient has at home? They need to have a meter, right? They need to have prescriptions for the insulins that they need. Do they have pen needles or syringes? Do they have test strips? All of those things are important to the patient once they get home. So all of these things are on the Good Day Ascension Diabetes Care page. And then obviously consult the diabetes care team. We've got 2 inpatient diabetes educators in Tulsa at main campus, and we have 1 in Bartlesville. If you're on today listening to this from Owasso, VA, or any of the other outlying areas, you can always call our diabetes offices either in Bartlesville or Tulsa, and we will get a diabetes educator to call you and kind of help you out if you've got a complex patient. Don't hesitate to call and ask us. But with limited diabetes educators, obviously, we can't see everybody with diabetes in the hospital, and that's why the bedside nurse is going to be leading the care. And don't forget, down here at the bottom, you can send an outpatient diabetes education consult. If you're thinking the patient, once they get home, needs to come in for some more outpatient education and support, go ahead and put in a consult. You don't need a provider's order. Just send it in. What we're going to do in our office is we're going to call the primary care doctor and get them to send us an actual order for it. So, okay. Well, thank you guys for attending. I think I've got some quiz questions. Let me make sure. Yep, I do. It's 9:08 though, so if you have to hop off, you totally can, but we're going to run through some quick quiz questions here in just a second. If you haven't already, go ahead and scan the QR code for attendance. I'll give you a couple seconds to do that, and then we're going to hop into the quiz questions. Okay. Okay, here's a case study. Mrs. Johnson is admitted for sepsis. She has a past medical history of type 2 diabetes plus hypertension and who knows what else. Her current diabetes medications that are ordered are 30 units of glargine every 24 hours and 8 units of Lispro TID-AC or TID food or AC, whatever you want, plus the Lispro correction scale of 140/15. At breakfast, Mrs. Johnson's blood sugar is 110. She ate all of her meal and received 8 units of Lispro. Upon entering the patient's room at 9:30, she complains of feeling shaky and sweaty. Obviously, you're going to check the blood sugar, and the result is 39. So what do you do next? A, do you give 4 ounces of juice, wait 15 minutes and recheck? Do you give peanut butter and crackers, wait 15 minutes and recheck? Do you push 25 mils of D50 over 2 to 3 minutes and recheck in 15 minutes? Do you call the provider to notify of the event and request a lowered nutritional insulin dose? Or do you offer the patient a snack following the resolution of hypoglycemia? And the question says, circle all that apply. If you have an answer, put it in the chat, or you can come off mute if you want. No guesses? Oh, Caitlin says C and D. Definitely C and D. But Molly says C, D, and E, and Molly, you're right. We do need to offer the patient a snack following the resolution. So it is, the answer is C, D, and E. Okay, current medications for Miss Johnson are still listed. It's 6 units of Lispro. After treatment of her finger stick blood glucose was 74, her lunch tray arrives a few hours later. Her blood sugar is now 98, and she eats 75% of the meal. What are your next steps? Check all that apply. A, you hold her lunch dose. B, you give the lowered Lispro dose the provider ordered at lunch. C, if the provider did not lower the insulin following the hypoglycemia event, you call the provider back at this time for guidance, or you escalate if no adjustment is made to the insulin dose by calling the house supervisor. Or D, you give the patient an extra juice to make sure she doesn't have hypoglycemia again. Thoughts? Molly, you are right, but what about B? The answer is B and C, because the doctor did lower it from 8 to 6. So give it. But if the doctor had not lowered the dose, definitely call them back. So what's the treatment written in our hypoglycemia protocol for severe hypoglycemia less than 54? Is it peanut butter and crackers and 4 ounces of juice? 4 ounces of juice, 25 mils of D50 IV push over 2 to 3 minutes, or any of the above? Yes, but the quiz on the QR code doesn't allow multiple. Oh, the QR code is just for your attendance.
I'll look at it and see. I included the quiz on there.
Okay. Oh, okay. Okay. Okay, back to our question. The treatment written in our hypo protocol, Kylie says C. And she is correct. It's C. Anything below 54 is going to get D50 nowadays. We're going to skip the oral route and go straight to D50 according to the new national protocol. What is the treatment written in our hypo protocol for mild hypoglycemia? So something between 54 and 70. Is it 4 ounces of juice? Is it 4 glucose tablets, a glucose gel tube, or 2 ounce glucose liquid? They're all equal to 15 grams. Peanut butter and crackers and 4 ounces of juice, or is it the 25 mils of D50? And Molly and Patricia both say B, and that is correct. B. Yep. Okay. Mr. Smith, a 60-year-old male, is admitted for an elective hip replacement. He has a history of type 1 diabetes. He arrived at the ortho floor at 1400 following surgery and still remains groggy. Admission was completed. The call light was within reach. Glucose was checked by your patient care tech with a reading of 285 and reported to the nurse at 1500. Post-op admission orders include, you can see here, Glargine 10 units at bedtime, nutritional Lispro dose at 5 units with meals, and the sensitive correction scale, as well as ASJHS finger stick monitoring. What is the correction or the correct action? Have the PCT recheck the blood sugar closer to dinner tray and then proceed with the nutritional and correctional scale doses. Make sure the patient has not had any corrective insulin in the past 3 hours and then give the correction scale dose for the blood sugar of 285. Call the lab for a stat glucose check to verify the reading. Or D, give correction dose and hold the dinner tray. This one's tricky. So the blood sugar was done at 1500. That's 3 p.m. The dinner trays aren't coming probably until at least 4 or 5, right? So the answer is B. Make sure the patient's not had any corrective insulin in the past 3 hours, because they may have given some down in recovery. They could have given some during the surgery. So just make sure that you're not going to end up stacking. Good job, everybody. You got that one right. Okay, here's our next one. Same patient, blood sugar at 1630, which is probably about dinner time, is 240. The dinner tray arrives at 1700 and the patient eats most of the meal. What are your next steps? This one's a little bit trickier. Not A. Remember, you just gave a correction scale. You just gave the correction scale dose at what time was that? 1500? So it's only been an hour and a half. That correction scale dose that you gave for the 280 blood sugar is just now peaking. So you're going to see that 240 is going to keep coming down. So really the best option here is to only give the nutritional dose of 5 units for the meal, because he ate well. He should get that dose, but wait on the sliding scale dose. Skip it because you just gave a dose an hour and a half ago. So that one was tricky. Made you kind of think it through. Little things like that are how we improve our hypo and hyperglycemia rates. At HS, so what are we going to do at bedtime? At bedtime, the blood sugar is 85. Thank goodness we skipped the correction dose, right? Do you hold the glargine dose at bedtime? Do you call the provider for a reduced glargine dose? Or do you offer a small snack to prevent hypoglycemia based on the hypo prevention steps? Or do you give the glargine at bedtime as ordered? Yep, Kylie says B. B is not wrong. You could totally call the doctor and say, hey, the blood sugar at bedtime is 85. I think we need to decrease just a little bit. I don't want to have hypoglycemia overnight. Some would argue you could do C also. You could give them a small snack and go ahead and give the dose and see how they do. If they drop low overnight with a snack, then yes, the glargine dose needs to back off. But either I would take B or C. But really, oops. Yep. Okay, I hope this one's our last one. Mrs. Kelly is a 26-year-old female with a prior history of type 1, diagnosed at age 22. She's admitted with mild DKA. She reports she hasn't taken her long-acting insulin because she hasn't been able to keep any food down for 24 hours. Big mistake. When type 1s get sick, they think, I'm going to drop too low if I take my long-acting insulin, and they skip it, and that leads to DKA. She does weigh 66 kilos. So at home, she takes 10 units glargine every 24. She takes 4 units of Lispro with meals, plus she's got a correction scale too, PRN for hyperglycemia. Her labs are seen here. You can see her pH is low, her bicarb's low. Obviously, she's acidotic. She's probably got positive ketones. What orders would you expect to see from the doctor? I will point out, notice I said mild DKA. She may not need IV insulin. Kylie says E, which would be all of the above. Everybody else agree with her? Because she's right. It's E, all three, or all four of those things you're going to see. What would you expect with the IV fluids? We didn't go into this too in depth, but it's going to be both A and B on this one, because they're going to be managing the blood sugar on the drip with the dextrose more so than the insulin. When should you call the provider for Mrs. Kelly? Obviously, if the gap is increasing or the pH is dropping or the potassium is less than 3.3, yes, definitely A. But also, anytime the blood sugar is less than 200, the bicarb or the anion gap have improved, it indicates that the DKA is resolving. So that's going to be both A and C. What other things should be done for Ms. Kelly before we discharge? Definitely review the Preventing DKA handout. You can get that off the Diabetes Care Good Day Ascension page. Provide her a diabetes survival skills notebook, and then consult diabetes education or refer her to the outpatient diabetes program. It's all of the above, D. Any questions? I'm going to go back to the QR code just in case somebody needs it. Any questions while I'm doing that about any of this? It was a lot of information. Well, if not, I thank everybody for taking the time to learn more about diabetes. It's going to make you a better nurse every day of the week. So if you have any questions or need any guidance, don't hesitate to consult diabetes education for your patients. You do not need a doctor's order for that. If you need us, consult us. We can come and see the patient. And if we can help you out in any way, just let us know. Thank you, guys. Have a great day.
Excuse me, ma'am. Excuse me, ma'am.
Yes.
Hello. Yes, my name is Emily Musila, and I work on tennis. And I've been listening, but I'm by phone. Are you taking a roll call? Because I don't have a QRS code per se.
Yes, we have attached these slides to this